of healthcare delivery and reducing physician burnout, two very important topics. She's also taken this interest to the national stage, where she's currently chairing an ACC work group on AI applications in clinical practice of AI doc. And previously, she co-chaired another work group between the ACC and the Consumer Technology Association work group on wearable devices and digital health solutions in hypertension and AFib. Effie's also a podcast host, and that's also focused on physician AI collaborations. And recently, she has obtained funding through our Quality Scholar program, also aimed at reducing barriers to outpatient echocardiography. So today, Dr. Andrikopoulou will present on the development and use of responsible AI to promote patient-centric care, improving clinical workflows, and ensuring equitable healthcare delivery to our patients. I'll hand you the floor, Effie.
Thank you so much, Nazim. Thank you so much, everyone, for coming in today. It's a pleasure. Like Nazim said, we are going to try to tackle today how we can use responsible artificial intelligence in cardiology and how we can use it to try to advance personalized patient-centric care. No, you're fine. Let me know when I can advance. Great. These are my disclosures. I did struggle a little bit with trying to figure out what would be the best way to structure today's talk. Obviously, I'm not a data engineer or data architect or a coder, and I didn't want this to be a cold talk on artificial intelligence and going over what it is, subtypes, and making it very engineering. So instead, what I think we can do brief overview of some of the key barriers that are still to this day causing disparities in healthcare. So to start with, has anyone heard of the Delmar divide, just by show of hands here? So the Delmar divide is, Delmar is a boulevard in St. Louis, Missouri, and it's a physical and symbolic line separating the southern affluent, wealthy part of St. Louis, which is predominantly white, high income, high housing value, access to high quality educational and healthcare resources. And this is separated by the Delmar Boulevard from the northern part of St. Louis, which is predominantly Black, disenfranchised, inadequate access to high quality education and healthcare, poor health outcomes. And this has been used as an example of a physical and symbolic line that really, really reflects the barriers that still exist even within urban areas. We're not even talking urban versus rural. And this, I don't think this comes as a surprise, especially to my colleagues who practice at Harborview or who get to practice at Harborview and other sites within the UW health system. We still, to this day, we see our patients who struggle to make it to healthcare appointments, especially at Harborview, where I have my general cardiology clinic. And this is due to a significant part because of non-health related issues. For instance, a lot of individuals might have challenging housing situations. They might not have enough family support. They might be the main caregivers for other family members. They might not have enough income or transportation access. And those factors are all collectively known as social determinants of health. And what's important to note is that they don't function independently and on their own. That would actually make it easy to tackle. Rather, these are all interconnected. And that's what makes it very, very hard to tackle them, because we're realizing that to tackle health disparities and inequities, we also have to tackle educational disparities, housing disparities, income disparities. And this is, for instance, this is an example from a recent cross-sectional study that showed that even to this day, there are still significant race-based inequities in the US. Things were better in the 1960s or so, 1960s to 1970s, but starting in 1970s onwards and up until these days, race-based disparities have continued to widen in the US. There's some suggested solutions that focus on policies to improve financial access to care and policies to improve trust of Black communities back to the healthcare by investing in facilities and investing in shortages of Black healthcare professionals. Sadly, none of this seems to really make a huge difference. In addition to race-based disparities, there's sex-based inequities. We all know, and there's growing evidence showing that it's much harder for women to get high-quality care. Women tend to present later in disease stage with more comorbidities, and it's been very well shown both in cardiovascular disease and in other disciplines that women have worse health outcomes. For instance, there's a 50% higher likelihood that women may get misdiagnosed after getting a heart attack compared to men. Only 38% of women are participants in clinical trials, and this is data from 2019. This is before COVID. After COVID, things sadly got worse. 52%, there's a 52% greater chance of women dying after 70 years of age in low and middle income countries. Women face a 4 times higher risk of developing autoimmune disease. And something that shocked me, honestly, is that 810 women die every day due to preventable causes related to pregnancy and childbirth. And women spend 25% more of their lives in worse health compared to men. And so it becomes obvious that we all, and by we, I mean, irrespective sex, race, our zip codes, we all have a right to evidence-based healthcare that meets our needs and is appropriate for our bodies. Back in January of 2024, about a year ago or so, there was a joint work that was released by McKinsey Health Institute and the World Economic Forum that revealed that closing the health gap between men and women healthcare would infuse the global economy with an additional $1 trillion every year by 2040. And so obviously we did mention that there's policies that have been tried out, but sadly none of this really has made a difference. And we don't have the time to go over every single policy, and I'm certainly not the expert to go over all of these policies. But maybe we can start thinking about how artificial intelligence could play a role in trying to bridge those gaps and improve these inequities. Since COVID, we've really seen an explosion in artificial intelligence, just looking at different metrics from publications to the interest of the public and consumer interest. AI has really been a really hot keyword. But I thought that maybe we can go over a brief historical context of AI in healthcare, which can hopefully help us see how it's evolved and how it can evolve to help us provide and deliver more personalized and patient-centric care. So back in the 1950s and 60s, we started with rule-based systems. This is called symbolic AI. This was essentially decision trees that were based on concepts like, if this happens, then we can do that. And one of the first, it's called like the granddaddy of AI in medicine. It was a rule-based expert system that was called MyScene. It's I don't know if I can, yeah, you can see with my pointer here. It was first developed in the 1960s, 1970s. And this rule-based system was based on infectious disease expert knowledge. And it was tasked with helping to identify different types of infectious disease and then recommend certain types of treatments. And it was succeeded by this tool that was called Internist 1. And this expanded to general internal medicine and not just infectious disease. These are heuristic models. These are models that are based on expert knowledge and not on raw clinical data. So this is experts coming together and saying, okay, here's how you diagnose X, Y, Z disease, and here's how you treat it. And so as you can imagine, there were a lot of important limitations that came with these systems. Number one, intrinsic bias, because again, they weren't really based on data, they were based on expert knowledge. And so if the expert knowledge wasn't built into the system, the algorithm couldn't provide with any insights, with any responses. And that's why it was very limited with real world cases. It was very brittle. And those were not generalizable and scalable because, again, they couldn't learn from new data. They didn't really have data other than expert knowledge. The transition period between these heuristic models to machine learning that we're going to touch on in a second were the probabilistic models, which is kind of like AI 1.5 era. The rule-based systems were AI 1.0. So these probabilistic models is things like Chad's VASC score or ASCVD risk calculator or the MESA risk score. These are more traditional statistical models that are based on data and clinical expertise. They bring the two together. And we use the data to have our input variables, but we also have clinical expertise and clinical knowledge to identify which variables are relevant. And then through traditional statistical methods, like Cox proportional hazards or regression, then we get the output of the model, of the algorithm. This was much better because as opposed to the initial rule-based systems, these models do rely on input of individualized patient data, patient's age, race, blood pressure, different types of comorbidities. And so they are more generalizable, they are scalable. The problem with these models is that they're still far from being truly personalized. And they can't learn from new data. They're built, they're done, it is what it is. We can't really integrate the algorithm and update it with new data. And for the first 50 to 60 years or so of AI in medicine, we were mostly using these probabilistic models. But around the 1980s, 1990s is when machine learning techniques and models started emerging. And one of the first machine learning models that was used clinically, it was, they're called CAD. I thought it was fun because CAD. But CAD in machine learning stands for computer-aided diagnosis. And one of the very first CAD systems that emerged was the image checker that was used to identify malignant lesions from radiology studies. And it was used on breast cancer, on mammograms. And that was, this publication is from December 1997. And again, in the 1990s, there were additional publications starting to use machine learning to identify and classify different types of diseases, for instance, interstitial lung disease or cerebral lesions in children. I do. I know we said we're not going to make it a engineering type of talk, and this is only the next couple of slides. But I do think it's important to understand how machine learning is different from traditional statistics and how it's taking us a step closer to personalized care. With traditional statistics, we start with our hypothesis or question, then we collect our data and we analyze our data to answer that specific question. However, with machine learning, we don't really start with a hypothesis. With machine learning, we explore the data, which is, you might hear it as data mining, to identify variables and features and identify patterns and correlations between those variables. And that's how we get insight from the data. So as opposed to needing a hypothesis to start with. And that's why machine learning has been used to predict clinical outcomes, diagnose disease states, classify different types of images, recognize speech, and recognize and generate language. And this is done mostly with supervised machine learning, all of these tasks. So supervised machine learning is the most common type of machine learning that we're using in clinical and research. And what we do with machine learning is we have our training data set that is labeled based on some ground truth labels. Just to make it easy, for instance, if I have echocardiograms, I will label the left and right ventricle. And then I will feed tens of thousands or hundreds of thousands or millions of echocardiograms to my supervised machine learning model. And every single structure in that echo is going to be labeled as the ground truth. And then I will ask my model to recognize the different structures, making sure that they correspond to the ground truth label that I've already given. This is the most common type of machine learning. There's also unsupervised machine learning where we do not label anything, any of the data. We have our training data set and we perform clustering and associations to leave it on the machine learning algorithm on the model to identify and uncover patterns and relationships amongst different data and different variables. And so I think of it as, you can think of it, or maybe I think of it as helpful, especially when disease states are very heterogeneous and we don't know a whole lot about them and we're having a hard time diagnosing them, like heart failure of preserved EF, or cardiac amyloid, or left ventricular hypertrophy, things that are very heterogeneous and we don't have a good sense of what they could be or what's causing them. Those could be decent cases for unsupervised machine learning exploration to reveal relationships and patterns that are hidden to us. In around 2010 or so is when deep learning started emerging. So deep learning is machine learning, but the way I think about it is on steroids, meaning that deep learning, the poster child for deep learning models is, not sure if anyone here has heard of this, is multi-layered convolutional neural networks, or CNNs. Those are used a lot in radiology. And radiology is the field of medicine that has that is seeing the most advancement in AI and deep learning. So what these multi-layered neural networks do, their unit cells are neurons, and they really function a lot like the human brain in that they are fed with data and they learn from data. And the great thing about this is that we can use very, very complex and very large data set that we can feed into them and train those models with. And those data don't have to be labeled. They don't have to be structured. So for instance, in our case, think about EHR data, which 80% of it is unstructured. Clinic notes, imaging studies, could be multimodal data. And what they can do is, it's kind of like an end-to-end solution. So we feed the data and we get the output of the algorithm. without having to have a data scientist work and supervise every single step of the analysis. With traditional machine learning, that's what we have to do. We have to collect our data, we have to extract the features and to clean the data, visualize the data, do feature engineering with traditional machine learning, and then we classify the data and we get the output of the analysis. With deep learning, we don't have to do any feature engineering. The data cleaning and data classification all take place at the same time, and it's an end-to-end solution. The fact that these deep learning models can process and analyze very, very complex and very large data sets does make it more expensive and more time consuming, meaning that it might take seconds to maybe a few hours for machine learning algorithms to analyze data. For deep learning algorithms to analyze data, it can take weeks. And that makes it much more expensive. They need higher computing power. They need more money, and so they're much more advanced and more costly. These deep learning type of algorithms and models started emerging in around 2010s or so, and we are still in the era, we're still very much in the era of deep learning right now. We're transitioning to the next era, which we're going to talk about in a second, but we're still doing a lot of deep learning, and we're still using it and learning a lot and growing our knowledge a lot using this kind of algorithms right now. One of the first studies that came out using deep learning techniques, which is also one of the most cited and visited paper in JAMA, was this publication right here from 2010 or so. Well, maybe I can't show it. But the one that talks about development and validation of a deep learning algorithm for detection of diabetic retinopathy using photographs, which was found to do a better job compared to ophthalmologists. And similarly, there's deep learning systems that have been used to diagnose and classify different types of skin disease based on photographs or path slides. They've been used in cases of pathology for prostate cancer assessment, lung cancer screening, breast cancer screening. It's been used a lot. And again, like we said, used a lot in radiology. In cardiology, in 2017, we had the first FDA approval of a deep learning system that was called Arteris Cardio DL. This was the first FDA-approved cloud computing tool that used deep learning. And what this tool did was it would get conventional cardiac MRI images, and it would then automatically measure the left and right ventricular volumes and mass and EF. And it was shown to do it as good or sometimes even better compared to expert physicians that read cardiac MRIs. Since then, and especially over the past 5 years or so, we've seen an explosion of deep learning in cardiovascular imaging, especially when it comes to echo, which is not surprising because that's what we use the most for cardiac imaging. For instance, Ultromics is a spin-off of Oxford University in the UK. They work a lot with Mayo Clinic here in the US to develop and train and validate their systems. And they've already been FDA approved for echo-based tools to detect cardiac amyloid and to detect heart failure with preserved EF. And the HuffPath detection tool is, I think it's cool because what they do is they use very few echo clips to spit out their output. And on the, Ultromic showed it to me, on the echo report, at the very, very bottom of the echo report, there's a statement that says, oh, this patient is at X risk of having HFpEF. And they also visualize the risk like from red to green, red, yellow, and green, and it shows where the patient falls under for having HFpEF. So I thought this is nice and sophisticated because it's not like they're saying, oh, this patient has HFpEF. They're risk stratifying the patient, and they're also trying to visualize that to make it easier to digest. The Envision is a company that's founded in LA. David Ouyang, who works for Cedars-Sinai, he's a cardiologist and a cardiac imager there. He's one of the co-founders. And they've also gotten FDA approved for their cardiac amyloid detection program using echo. And their group has also done a lot of work trying to use deep learning techniques to classify different types of left ventricular hypertrophy on echo into HCM, hypertensive heart disease, kidney disease. And most recently at this last year's American Heart Association conference in Chicago, two groups, one from Yale and one from Cedars-Sinai, showed their work using deep learning techniques to make echo faster and more accessible. So they were able to show that they trained algorithms to end-to-end solution, like we talked about previously, to measure, interpret, and report echoes. So then it only takes human if you want to supervise the final output. Deep learning techniques have also been used to detect mitral regurgitation on echo, as well as to perform myocardial strain on echo. And in the picture in the center where I'm showing 4 echo pictures, this is an example of using a deep learning tool that's built in a POCUS device, in a point of care ultrasound device that has deep learning built into it, to guide non-sonographer operators into doing echoes. And so these are examples of echoes that were done by nurse practitioners in rural areas doing an echo on their patient in clinic. Another field of cardiology that is seeing an exponential growth of AI is cardiac CT. Again, like I mentioned previously, radiology, there's now about 1,000 or so FDA-approved AI medical devices. 80%, the vast majority of them are in radiology. Cardiology is second, but it's a far second. But within cardiology, cardiac imaging is the subfield that is seeing the most expansion and use and adoption of AI, because we are at the intersection of radiology and cardiology. And so with cardiac CT, there's an expansion of AI, predominantly with HeartFlow, and clearly UDAP is partnering with HeartFlow. And they have traditionally used computational fluid dynamics to perform FFR CT, but they're now also using AI and deep learning instead of computational fluid dynamics to derive FFR values from their cardiac CT studies. Clearly, on the other hand, is not focusing so much on FFR CT, clearly is focusing on using AI and deep learning to do advanced characterization of atherosclerotic plaque within the coronary vessels. And so in addition to giving information on the presence of calcified, non-calcified mixed plaque, and whether there's associated stenosis and whether there's associated positive or negative vascular remodeling, clearly is also providing with quantification and characterization of the plaque itself to risk stratify patients. And there have been 2 studies so far. One is the Credence and one is the Pacific study that where clearly was tested out. And in the Credence study, I think it was based on 168 cardiac CTs. It was shown to be superior to FFR CT and nuclear stress testing for identifying patients with invasive FFR of 0.8 or less. And in the Pacific study, clearly was shown to be the only non-invasive test to independently correlate with future risk of major adverse cardiovascular events when it was compared to oxygen, water, PET-CT, and FFR-CT. And that brings us to radiomics. I did want to touch a little bit on this because you might come across it in publications. Radiomics is a combination of radio for radiological sciences and the suffix omics, which is used a lot in biology, like genomics, transcriptomics, proteomics, to collectively describe the data that we can obtain to classify disease and diagnose disease. The really innovative thing about radiomics in cardiovascular imaging, here I have an example of using cardiac MRI radiomics, is that we can explore and collect and analyze large, I'm talking vast amount of data. Imagine having thousands of MRIs. And we can get to pixel level assessment of quantifiers of tissue shape and texture. This is truly innovative because in practice, what radiomics holds the promise for is to uncover things that we cannot appreciate with our eyes. Because all of those tissue shape and tissue texture markers and quantifiers are not appreciated by us. This holds the promise of leading to earlier, more sensitive diagnosis and recertification of disease at subclinical stages. This is an example of a study that was published in 2020. These investigators used the UK Biobank dataset that has about 5,000 cardiac MRIs, and they compared CMR radiomics to conventional cardiac MRI markers, parameters. And they looked at patients who didn't have overt cardiovascular disease. They looked at patients with diabetes, hypertension, dyslipidemia, smokers. So risk factors, but not overt disease. And they wanted to see if features derived from radiomics would identify patients at risk better compared to conventional markers. And not surprisingly, that's what they found. So the promise with radiomics in cardiology is to help us identify and risk stratify disease at subclinical stages before overt dysfunction develops. So we've talked a lot about the different types of techniques. I do want us to talk a little bit about some of the applications. I thought this was an interesting analogy between a car and a human, and a dashboard versus a health monitor. And I think one of the prime examples of AI tools to advance personalized care is honestly AI EKGs. And whenever I think about AI EKG, I think a lot about things like smartwatches or even our traditional 12-lead EKGs. This is not, oh, could this happen? All of these things that I'm about to say about AI EKGs are happening. There is a vast amount of data, and it's well validated that we can perform deep learning analysis of our EKGs to uncover future risk of disease. And there's been studies that have validated the use of AI EKGs in patients who are in sinus to predict the risk of developing paroxysmal AFib in the future. There's been studies that have looked at doing deep learning analysis of EKGs in patients to predict the risk of developing left ventricular systolic dysfunction or other diseases like hypertrophic cardiomyopathy, transthyretin cardiac amyloid, or even valvular heart disease like aortic stenosis. And all of these risks can be derived from just looking at a person's EKG. And what's really innovative is that now there are studies that are showing that they can train and validate algorithms to not need 12-lead EKGs, but just single-lead EKGs that we can get from our smartwatches or stethoscopes that have AI built into them. For instance, this top row here, this right here, is showing an example of of a dashboard that they have at Mayo. They have an AI ECG dashboard where patients' MRNs can be entered, and then their EKGs can be analyzed for the risk of developing silent AFib or left ventricular systolic dysfunction or hypertrophic cardiomyopathy. And another thing that's important to note, this is, this is showing an Apple Watch. Earlier in 2024, Apple Watches got approved to be used as clinical research tools to detect AFib. So we can use Apple Watches and smartwatches as part of our clinical trials to detect AFib. Some people are saying that they're not a huge fan of smartwatches because they have to remember to wear them and collect their own personal digital health data. The future of wearables is what this picture here is showing, with wearables going from head to toe, from glasses and mouth guards and clothes and belts and shoes and socks and headsets. And it's the kind of wear and forget type of wearables. And it's obvious how this will, I think, will revolutionize the way we deliver care, because individuals won't really have to come to the doctor's office to get their health data collected. Individuals, just consumers, are going to be collecting their own health data. And so I think as clinicians and health systems, we would have to shift our mindset and practice from focusing on treating disease and patients, focusing on promoting health in hopefully healthy individuals and consumers. Along similar lines of monitoring disease state is telehealth. Obviously, COVID was what catalyzed telehealth. I know that we just got an email recently that said that, we don't know if we're going to be able to continue doing telehealth or if we're going to continue to do phone call visits or video visits. This is just my very personal opinion. I think telehealth is here to stay, and we are going to continue doing telehealth in the long run. Short term, there might be some back and forth, but I see it in my patients, and not just my more affluent patients, but also my disenfranchised patients who prefer telehealth appointments, because they might have some barriers to coming to clinic, like taking care of a sick loved one or not having reliable transportation. By telehealth, though, I don't just mean video visits or phone call visits. Telehealth is anything and everything from remote monitoring of symptoms with, like we said, using your Apple Watch to monitor your heart rhythm or heart rate, to having PA catheters and monitors or pulse oximeters, to smart pill boxes and monitors and wearables to measure blood pressure, diet, weight, and smoking. What I did want to show here, to include with this graph here, is a study that looked at no-shows and adherence to outpatient ambulatory clinic visits. And they compared telehealth to in-person visits. And they found that no-shows were, the gap in no-shows was reduced significantly with telehealth between whites, blacks, and Hispanics. Which, again, like I said, I honestly see that in my clinic as well. The problem with telehealth is that we're still far from having reliable broadband access and reliable Wi-Fi everywhere, even comparing urban to rural areas, but also within certain urban neighborhoods and zip codes. So there's still work to be done if we want to really use telehealth to advance patient-centric care and narrow inequities. There's still work to do on a bigger and policy standpoint to ensure reliable access to broadband and Wi-Fi. Natural language processing, I know we touched a little bit on it earlier, but I did want to take a second here and show some examples of how we could use natural language processing. Natural language processing, or NLP, is a subset of machine learning and deep learning that can explore and mine language data. In our case is text. Think about EHR data. The great thing about it is that this data doesn't have to be structured. It doesn't have to be in table format or labeled specifically. Like it doesn't have to be, you know, where we see vital signs, for instance. It could be any word, any sentence, any phrase that goes into our clinic notes, patient communication notes, any of our reports, anything really. And there have been studies that have developed and validated the use of NLP models to classify and diagnose different types of LVH into hypertrophic cardiomyopathy or not, or into cardiac, to predict the development of cardiac amyloid using EHR data, as well as to identify, to do EHR data mining to identify undiagnosed cases of heart failure with preserved EF. Our group used NLP to train and validate a model to predict the development of severe aortic stenosis from moderate aortic stenosis. All we used for this study was echo reports, and we extracted every single phrase and sentence and word, that everything from numbers to words that made it to those echo reports. We trained and validated internally the model among 7 hospitals, and then we externally validated it in 1 hospital. And we found that the F1 score from the internal validation was pretty good, but for the external validation was modest. This does show that there's still work to be done, A, to ensure that data needs to be high quality, and B, it's also a good example from our own work that shows that what the data that we use to train and internally validate a model matters, because maybe that data and the model that we're building based on that data isn't generalizable and scalable to other patients. This highlights the importance of using the right data on the right population to predict outcomes. UDAP is partnering now with an AI company that does EHR data mining using natural language processing. They're called Tempus Next. And I've had experience with them from UAB in Birmingham. And I just wanted to put this here really quickly as an example of what we can do with partnering with that company. And maybe this can be some food for thought for everyone here, because we can use them both for clinical as well as research work. But basically what we can do with the tool that we're about to start using and integrating into our clinical and research workflows is we use their product and their modules to extract EHR data from clinic notes, radiology reports, lab tests, you name it. Anything that's in EHR can be extracted. And then we can use that to build clinical workflows. For instance, what we did in Birmingham was we would mine data from echo reports to identify patients with severe aortic stenosis or severe mitral regurgitation based on numbers or text from the echo report. And then what we did was we would automatically send a notification to the ordering clinician's inbox that said, hey, your patient was identified as having severe aortic stenosis based on their echo, and based on the most recent clinical guidelines, you might want to consider referring them to UAB Structural Heart Valve Clinic. And here's how you can do that. This was just purely based on echo data, but it worked well. And then we started building more algorithms for sudden cardiac death risk stratification or identification of patients with heart failure that should be referred to cardiology or advanced heart failure. And these algorithms were based on multimodal data, meaning data from clinic notes, data from echo reports, lab tests. And when we looked at performance of those algorithms for patients with severe AS and severe MR, we observed two things. Number one, not only were the patients starting to get more timely management by more timely referral to the structural heart valve clinic or more timely performance of a follow-up echo or TAVR or MitraClip that you can see here. This is the structural heart valve clinic time, and this is the time before versus after implementing those algorithms. So you can see that it used to take, embarrassingly, over 200 days for someone to make it to a structural heart valve clinic versus less than 65 days. But we also noticed something else that was very eye-opening, and if anything, it led to more questions than answers. But we also noticed that compared to prior to implementing our AI algorithms, there was an improvement in the time to appropriate follow-up management for patients with severe AS and severe MR. And it was seen both for Black patients, shown in red, as well as white patients, shown in blue. And just as a reminder, this is the US South. That's why we focused on Blacks versus whites. But we saw that the improvement in timely management was much, much more significant and impressive for Blacks versus whites, where the lines start overlapping here. Obviously, this is retrospective analysis of data. There's no way we could say that this is because of implementation of the AI algorithm. Obviously, this is the result of a lot of different factors. But to me, honestly, it was very eye-opening seeing the discrepancy in care and uncovering maybe unconscious implicit biases that we have when we practice. We're getting close to being done, I promise. Before we talk about large language models and foundational models, which is the latest advancement, I do want to briefly also present here a couple more ideas of how we could use AI for targeted interventions. On the left-hand side, you see an example of an AI geospatial tool. And these are neighborhoods and areas in Chicago. And here is a heat map of different social and economic classes, and mortality rates from cancer. So here, what they did, the investigators used a geo-mapping tool to identify areas who are socioeconomically disenfranchised, and they also looked at mortality related to cancer in those areas. And the idea and the concept behind this is that perhaps we could use AI for geospatial identification of areas and regions and neighborhoods, even within cities, where individuals and residents are at higher risk of adverse health outcomes. And we can use this information to focus and target our interventions, like here, like showing the correlation between cancer mortality rates and socioeconomic disenfranchised areas. So this is looking at kind of like a 30,000 population health intervention. This here on the right-hand side, it's looking at individual person level intervention. I'm still reading up on this, but I'm very fascinated by this concept of digital twin. If I can explain it, digital twin is, if you can imagine having a digital copy of each one of ourselves, where we constantly feed it with digital health or EHR health data. For instance, I can feed it with sensors data from Apple Watches or a smart glasses or smart belt. And then I can also feed it with my EHR, MyChart data, or with my telehealth, smart pillbox data, or my weight or blood pressure data. And it can create a digital simulation of what's going on in my body and can make predictions and risk stratifications for my future health state. And then these can be fed back in this information and output. I can receive it. And then hopefully that can proactively make me more aware of my risk for future disease. And then that can hopefully lead to recommendations for earlier treatment and lifestyle recommendations and treatment recommendations for preventing those diseases, since I can predict them based on the digital and EHR data that is fed into my digital twin. So I think this is very fascinating. There is research going on right now. A lot of this research has to do with cancer and predicting risk of cancer using digital twins. It's very early on, but I think it's fascinating. And so we are going to conclude with this fourth era of AI with foundational models and generative AI. We are going to get to the large language models. Large language models and your ChatGPTs and whatnot, these are a subset of foundational models. But foundational models is, if we can picture this, if we can picture a foundational model, it's a very generalized model, AI model that is fed with vast and very complex multimodal data. This data can come from medical records and EHR to imaging studies to genomic data to personal digital health data coming from smartwatches or monitors at home, anything you can imagine. And then this data gets analyzed by the foundational model. And then the output of the analysis could be summarizing medical records. It could be predicting risk for disease or classifying disease or predicting imaging abnormalities. This is the differentiator for foundational models, and what makes them so innovative is that we don't have to keep retraining the foundational model with new data every time we want to perform a new analysis. So far, the things that we've talked about, whenever we want to do a new analysis, we have to train the model with new data. For instance, going back to our group's algorithm that predicted severe AS from moderate AS, we cannot use this algorithm to predict severe MR from moderate MR. Foundational models are different because they get trained on this vast body of data set. I'm talking about billions and trillions of data sets. And they use this training as a universal kind of backbone to adapt to answering different types of questions. So we don't have to keep retraining them every time we want to answer a different question. Large language models is a subset of foundational models and the most commonly used type of foundational models. Think about your ChatGPT, your Gemini, these kind of models. And there's also medicine-specific large language models like the one here, the PubMed GPT 2.7 that was developed by Stanford. And the goal here is to use PubMed data to create this interactive large language model where we can use it kind of like a ChatGPT and ask it medical questions and research-related questions and make it interactive. And here I wanted to show an example of a tool that I use after one of our internal medicine residents introduced me to it. It's called Open Evidence AI, and it's a co-development from Stanford and Yale and lots of other academic institutions. And again, this is kind of like your medical ChatGPT. I still double check the references that it's showing me, but so far, whenever I've used it, the references have been accurate. So I'm pretty satisfied with it. I don't use ChatGPT for medical questions, but I use this one. And those large language models are really doing natural language processing type of analysis, like text generation, summarization, and answering questions. They're different from deep learning models because, like we said, they can perform a lot of different types of analysis without needing retraining and new data every time we ask them a question. Their goal, their focus is to generate new content and interpret and respond to complex questions, as opposed to just predicting or classifying disease. They do self-supervised learning from those large data sets. And the goal here is, so the way to imagine how we train a large language model is we feed it words. And then we ask it, the expectation and the ask from that large language model is to predict what's the most likely next word to follow. And every time when we train them, every time the model gets it wrong, we flag that, the developers flag that, and that trains the model to reanalyze and reclassify and create new relationships between the words. And then this happens again and again and again, a lot of iterative cycles, until at some point you ask a question to the model, and then hopefully it gives you the most likely next word to follow, which is the correct one. The problem is that it can hallucinate, it can come up with the wrong words and come up with wrong answers. And there's still intrinsic bias that's related to the data that we feed into the algorithm. It really relies on high quality data to give high quality answers. Before we touch on some of the limitations and caveats, I do want to summarize here some final thoughts on how we could use AI in clinical research. And if we could summarize it with just 3 main bullets, that would be: use AI, be that foundational models, large language models, to help us analyze vast data sets of multimodal data, imaging, labs, vitals, biometrics, clinic notes, to identify people who would be eligible for trials in a more efficient way, to enhance recruitment efforts, engage with participants in better ways and in ways that each participant would appreciate. And most importantly, like we said, the quality of the data that goes into those models is the most important aspect of building the model. Similarly, the quality of the data that we use in our clinical research is the most important aspect of our research. And so we could hopefully use AI, use this as an opportunity to use AI to ensure diverse and representative participant populations. Sadly, we're far from the era where we can just use AI to solve all of our problems. There are a lot and significant limitations and caveats. We're nowhere near being able to use AI in an unsupervised way without human supervision and monitoring and double and triple checking. The most important caveats to me honestly have to do with the risk of propagating bias because of poor quality data. We still need a lot of regulations, both from a healthcare and a governmental level to regulate and oversee the development and validity of AI. Sadly, a lot of the FDA-approved tools are not extensively validated the way they should be. And again, going back to the problem of bias, last thing we want to do is build algorithms that, instead of bridging disparities and eliminating biases, we don't want to build algorithms that will propagate and expand biases. And sadly, we've seen that both in medicine, which I'll show an example in a second, but also outside of medicine. There's policing bias that's sadly built into AI tools that police uses. There's bias in algorithms that are used to identify candidates for jobs. And there have been studies that have revealed biases in healthcare risk calculators. For instance, commercial insurance carriers use population risk calculators to identify how to assign different coverages. And this study revealed that because the wrong marker was used as a surrogate of health, in this case, that this insurance, this commercial insurance, was using a risk calculator that used healthcare expenditures as a surrogate of good health. It falsely thought that Black patients, because they had lower healthcare expenditures, they were also more healthy, which is exactly the opposite. So they weren't offered as good resources and coverage as white people, as white individuals, because healthcare expenditure was used as a surrogate of health, which was the wrong one to use. I would encourage you guys to take a look at this publication from Circulation from AHA that really gives a very nice summary of how we can use AI to improve outcomes in cardiovascular disease. I really liked it. I used it a lot for my talk. And in general, I want to close with a sign of optimism. I am an optimist too, and I think that we can use AI to improve the quality of care that we deliver, to develop strategies for delivering personalized and patient-centric care. But we do have to be very mindful. We have to be very careful. We have to be very meticulous about it. I think that we are given a chance to make things right and bridge inequities using AI. Not the only tool, but one of the tools. But I do think that we have to really take our time and be very careful with it. Thank you so much.
Effie, I know we're a little bit over our time, so is there any questions from the room? There's a couple of comments online that I can also read. Okay. Chinonso is not here in person, so I'll be Chinonso today. He's asking, what do you make of AI medical reference tools like Open Evidence? I think you touched on that.
Yeah.
Dr. Otto says it's a very interesting and informative talk with methods that will dramatically change research and clinical care. She also says, I have found that one needs to be careful using AI for summarizing medical literature. It can be very quick, but data should be double checked.
Agreed. Yes, absolutely. Yes. It's a nice starting point to get started with some references, but then we still have to do the majority of work for sure.
Great. Just one question then. On the physician burnout side of things, how do we prevent this from turning into another epic and creating more work?
I agree.
Rather than facilitating work?
Yes, I think it's a huge conversation, but I think one key part is to have physicians at the table. We need to be at the table where decisions are made, and we need to actively make sure that we engage with these AI companies that build solutions and tools to serve us. I don't know if physicians were involved when Epic was first developed, and if physicians were involved and at the table where decisions were made, how to use Epic and when to use Epic and how to roll it out and what features to use. But I think with this, we're given a second chance to make sure that physicians and clinicians and nurses and patients and family members and patient representatives have a seat at the table with those companies, so that they build tools that serve us and they don't train us to serve the tool. Because right now, I think that's what's happening with Epic. Thank you.